Well, thank you guys for letting me come in and talk. It's a real informal lecture, so anytime y'all have questions during this, just stop me. We'll talk about it. We'll shoot the breeze, whatever. Uh, I don't think, like Nick says, I'm a professional at it. I've done it a time or two. And it sounds like a scary process when you do it, and sometimes it can be. When you do it, make sure you have a little extra deodorant on, because actually you're taking somebody's ability to breathe away when they may have been breathing fine. But these could be some difficult airway times, and this is not a difficult airway class. That's a whole another lecture. We'll talk about some backup airways, and I got a few here we'll go over toward the end of the class. But once you take somebody's respiratory drive away, I mean, it's gone. We got ways to breathe for them by bagging them or whatever, but it's not something you want to do. You want to get this tube on the first, second try, and if you don't get it, then it just goes downhill from there. So again, I'm Brent Wilson. Like Nick said, I work for Lifesaver, been a flight nurse with them. Actually, I started as a paramedic, went to school here, so I was in the same chairs that you guys were. Finished paramedic school in 2002. Worked as a paramedic for East Alabama for about 3 years while going to nursing school. Got out of nursing school in 2005 from here. Started flying for Lifesaver as a paramedic in 2005, worked in the ER some. Did a little time at Children's Hospital in Atlanta, and then moved back here. But all the time I was still working for Lifesaver. In about, 2007. First 2008 I started flying as a flight nurse. 2009 took over as the little base manager position, but I didn't tell anything but listen to complaining and doing the time and payroll. So it's not all it cracks up to be. But it is a fun job. We like it. We do see bad stuff. Everybody tell. It's like, oh man, y'all see all kinds of bad stuff. Well, actually, you guys are the ones that see the bad stuff. We don't get the calls of the ones that are already dead and mangled and tangled up. So you guys are the one that sees the bad stuff. We see the bad stuff that's still alive. You guys will see the worst of the worst. And been there too. Saw some bad stuff. So anytime, feel free to stop me. If you don't understand something, let me know. We'll go over it. And this is a slide that's already built. I modified it a little bit. Kind of based it on the state protocols. We had a modified RSI that we used to use, but this is actually based on the state protocols and what we use now. So we'll get started here. Go on in. So what we want to do with this is to establish and maintain a patent airway, and patient requiring an intubation through the meds that we have to give them to help. So times that you want to do an RSI, anybody think of something right offhand? We need to take somebody's respiratory drive away and place it and give them an ET tube or something. Somebody just named something.
Major trauma.
Trauma, burns. The burns they're iffy though. We have talk with Dr. Melton, who's our medical director. She's I guess the head trauma surgeon at UAB. They call her Scary Sherry sometimes because she's so mean, but I kind of suck up to her and she lets us do whatever. But we bring these patients in and we kind of ask them, what would you do, things like that. So burns are a different story, but it can be a time you want to RSI somebody. People that's had strokes, vomiting, things like that we're not going to be able to control the airways. And what we got to think about, you guys are in the truck, you have a little more room. We're in the helicopter, and we don't like to intubate in the helicopter, but we will, just because it's hard to verify because you can't hear and it's a small space. So we'll go ahead and we'll RSI them before we lift off or at the scene. And we don't RSI everybody. We may do 1 or 2 a month, so if that. So we don't do it a lot. And sometimes we'll go months without intubating anybody, and then we may do 5 a month. So when somebody's got an intact gag reflex, of course, if they're totally unresponsive, you can pass the laryngoscope in their mouth, throw a tube in. They don't need RSI. You can always attempt it, and if they don't need it, intubate them. That's less drugs that you have to give. They've got some hemodynamic properties. You want to take the blood pressure and stuff away, even though the ones we use right now don't really affect that much. So if they don't need the meds, don't give it to them. If they're combative, and again, I base all this around flying. We don't want anybody kicking the pilot, we don't want anybody opening the door, kicking the window out when we're, 2,000 feet off the ground, and, that's kind of a bad situation. We just don't have the room to restrain them, so we'll use chemical restraints. We hardly ever use physical restraints on our patients. GCS lesson 8, they say intubate, but that's also a fine line when you get out in the field. That's kind of the book, and I'm going to teach a little bit of the field side too, but always for tests, make sure you answer by the book. You know, if somebody's breathing okay and they're doing well and they're keeping their sats up, you don't really want to take their respiratory drive away, especially if they're going to be a difficult airway, and that's what we'll kind of look at during this class. If you think they may crash en route, you may want to go ahead and RSI them if you got extended time to the hospital. I mean, if we were here and we were going to East Alabama, we could bag them that far for a few minutes, but if we had a 20-30 minute time, we probably want to RSI them. And RSI does take some time, and especially if you're not familiar with it, you got to get all your stuff set up, and we'll go through that too. So it does take a little bit of time. So in the meantime, you could be kind of on the way to the hospital. Trismus, people we know that's clenched down, trauma. If they vomit, their teeth are clenched down, so they don't have anywhere to go but in their lungs, so they aspirate it. So we get some sucks, and that'll usually relax them. Get a tube down in there. Laryngospasms, you see those every once in a while. Seizure activity that won't break will be an indication for it. Contraindications, this is the most important. So inability to ventilate the patient with a BVM. So what if we don't get this tube? What are we going to do? How are we going to ventilate them for the 5-7 minutes that it takes for the sucks to wear off? I mean, that'll kill somebody right there. Have a noxic brain injury at least. Beards, large obese people, things like that. If we're not going to be able to ventilate them well, massive facial trauma, if we can't get a good seal on their face, and they're doing okay with their breathing, we really don't want to take their airway away from them. We do, or can do, needle and surgical cracks. I've never done one. I think there's only been 1 or 2 in the state of Alabama, like in a couple of years. So it's not something we do. We know how to do it. Would I be a little shaky when I was doing it? Yeah, because I've never done it. I've practiced on it, but never done it. And the ability to perform intubation effectively and safely without RSI medication. So again, if you don't need it, you don't need RSI. Things to look for, and a lot of this stuff is based on like anesthesiology, CRNAs. If you ever been with somebody that's going back for surgery, whatever, you get an anesthesiologist come around. But trauma, again, these people are unresponsive, they're combative. They're not going to be able to open their mouth and look at it and see. But if you're getting ready to RSI somebody, that's what you would want to do. Usually we have to call for orders. We call Dr. Melton and Dr. Kirby at UAB, and sometimes they'll ask for this. And they were really asking a lot when we first started RSIing people, and we had to get orders for it. Again, we used to use a modified version. We would give Tomidate and Versed. That would usually relax them enough that we could intubate, but sometimes it really wouldn't. They would cough on you, and they would have a laryngospasm. You could see the tube. You just couldn't get that tube in there. You just ram it in there. But once we started using sucks and Tomidate, I mean, our intubation percentage success has gone up because they're relaxed. You just slide that tube in there. They're not fighting. They're not coughing like they would with a Tomidate and Versed, which if you don't get it, the Tomidate and Versed will wear off. They'll still breathe. So a lot of times they would ask for this.
So is the like the class 3 and 4 are they going to be like contraindications?
Not contraindications. You just know that you better have your crap together when you start to intubate. Oh, hit that. This is probably pictures a few slides ahead of what it should be. So you got the mountain padding, the classes, and then you go to grades. So, and this is when you introduce the laryngoscope. This is what you want to see a 1. Smart board for dumb people. Doesn't work out. So you want to see that 1, but that's bad. That's okay because you can see something. When you get to a grade 4 airway, you're just praying and hoping and pushing. And I'll jump ahead a little bit. Anybody ever seen one of these? Bougie. Lifesavers. That's what they are. And we will, just because somebody's thin, and you may have learned that obese people don't usually have very good airways and they're hard. Well, they are hard, but I've seen thin people that are worse than that. For some people, they're real anterior, they'll say. So if you can even see that, say that's a grade 3 right there, that's all you want to see is just that little hole right there. You can take this thing, and usually it's fairly flexible. You can get it right where you need to be. You stick that in, and then hold it once you see it go past through the vocal cords. Sometimes you can feel the rings in the trachea, intubated one. The day before Friday, you could feel the rings in the trachea as it was going down. I didn't know if it was in there or not, but I could feel that sometimes your partner, if they're holding crite pressure, they can feel you kind of bumping around. You just take your ET tube and slide over that. Keep a laryngoscope in their mouth, slide over it, watch it go through. That way you kind of know your depth. So these are lifesavers. We'll break these out on almost every patient. They're maybe $10, $15 a piece. I don't know. So, but they do help. So make sure you always have that ready.
So when the meds wear off, do the respiratory drop from that?
It will. But if you don't have a way to ventilate them for 5, 7, 10 minutes on sometimes, some people eat through it pretty fast. Yeah, I mean, what are you going to do? So, but they do wear off. But as we get into the lecture, once we paralyze them, I mean, they were kind of awake a little bit before we gave them the meds. We gave them sucks, which is a short acting, which we'll get to. But then once that sucks wears off in about 5 minutes and Tomidate wears off in 5 minutes, now they're intubated and pissed off. So they're going to be pulling, they're going to be crashing. So we'll give them something else a little bit stronger. We'll get to that. Again, on the patient assessment, this is a 3-3-2 rule right there. 3 fingers in the mouth. 3 fingers from the chin to the neck, and 2 fingers from the mandible to I got the thyroid notch, which is actually higher up thyroid bone. Okay, everybody do it. 3 fingers in your mouth. I had to count my fingers too. Right. You got it good. If you get it in there, that's what you want to see on people. If you can get 3 fingers in the mouth, I mean, they can't. It's going to be hard to get in there and see. So look at that before you do it. 3 fingers in the mouth. We want 3 fingers from the neck there to the tip of the chin. You got some people that just don't have a neck. Some people don't have a chin. There's some health conditions. People's chin just drop off. Those people can be hard intubations. And you want 2 fingers from the right under your chin to your hyoid bone. Most people can usually get 2 fingers right there. Not a big deal. So the 3-3-2 rule is a good assessment too. And now when you're in the grocery store, Walmart, you're going to start looking at people like, damn, we want to intubate me. Or there'll be an easy intubation. So things to look at, and when we hop up in the back of them, it's like, oh man, this is going to suck. And then, some people are pretty good. And like I say, even if they look good, they may not be. But most of the time, the big ones are the worst ones. We use the mnemonic lemon a lot. So look externally. Do they have a beard? They have a facial trauma? A lot of bikers, stuff like that. Have these huge beards, huge goatees. You can't get a good mask seal if if we have a failed airway. We have to bag these people. What kind of teeth do they have? Do they have false teeth? Do they not have any teeth? Sometimes having no teeth is a bad thing too, because everything just falls back in their mouth, and it's hard to scoop that tongue out of the way and get to it. So look and see if they have false teeth, or if they don't have any teeth, they have false teeth, you can take them out, because sometimes once you get in there, those things start falling every way. So they have a partial. The E is the evaluation 3-3-2 rule. M is malinfality that we talked about. O is obstruction. Do they have a tumor? Do they have anything weird? Do they have something going on in the throat or neck? Do they have some sort of trauma where they have a hematoma there? Abscesses. Do they have epiglottitis, if it's kids or things like that, or have hematomas or trauma? Just take all that stuff into account. Like say if they're breathing good or breathing okay, and we know or think there'll be a difficult airway, and we think we can make it to the hospital, go ahead and, you don't have to RSI everybody just because they have an indication for it. It's kind of what you feel like they need, but if you don't think it's going to be an easy airway, and you can hold off on that intubation, do it. That's just a bad feeling not being able to get somebody intubated. Neck mobility, chin to chest, trauma, they're not going to be able to do it, of course. Tell them throw their head back. Like I say, if you go to the OR, y'all still do clinicals in the OR? Took it away. Those are great because you can just jump from room to room and intubate people. I wish they took that away. So when you hang out with an anesthesiologist, whatever, if you have somebody in surgery, that's what they're going to do. They're going to go around, put your chin to your chest, put your head back. Again, this is not a difficult airway class, but if you can throw that head back, it kind of lines everything up a little bit better. Trauma, contraindicated. It's a lot harder because you kind of have to start looking up. But if you can throw a head back and drop it off the stretcher, it lines everything up. If it's kids, you can put towels under the shoulders to line everything up. So the more you can move the head, the better. So people you want to intubate, strokes, seizures, non-trauma cases, get your partner and me just crank that head back as far as it'll go. So literally their back is almost arched off the stretcher. And that helps you line everything up a little bit. It may be cheating, but hey, at least you'll get airway. Don't be afraid of cheating. It's fair game. Trauma's a little bit different. You may see us take the collar off a little bit, and we may have to move the head a little bit. We usually try not to, or we're not supposed to, but you may see us give us some crack pressure or something like that. So we'll usually pop a collar and get somebody to hold the sound cool down. Pop that collar. Three for the cool roll again. The 5 P's of RSI. Preparation is the most important. First thing you do, if you know you're going to intubate somebody, they probably got a non-rebreather on anyway, just crank it. Not 15 liters, I'm talking about flush. 25 liters, whatever it'll give them. I'm talking wide open. They're still breathing okay, and we'll show you why in just a second. So I think pre-oxygenation should be first. So that's like the first thing you want to do is crank that O2 wide open, as long as you're breathing. Preparation, you want all your stuff out, because if it's out of arm's reach, it might as well be in the next room. You don't have anybody get it to you. You want your laryngoscope, you want the right blade, you want your ET tube with your syringe on, you want suction, stick it under the head of the stretcher, stick it under their head, stick it under the backboard. You want that. You want your bougie ET tube, what else I'm missing? You want your tube security device, whatever you want to call it. Commercial ones work really good. That's what we use. I never had good luck with tape and stuff like that, because it's just aggravating to get under somebody's head and wrap it around, and blood, and it doesn't stick. So those little tube security devices with the screw on it, everybody seen those? Mm-hmm. Yeah, they usually work pretty good. Pre-treatment in the state, they've been back and forth. It's almost like snake bites and everything else. What are you doing this week? Oh, we're putting a tourniquet on. Next week we won't put a tourniquet on. Pre-treatment, talking about lidocaine and atropine, and they recommended, and then they took it away, but the state protocols, it says lidocaine for head injury patients. This causes when you're intubating and keeps some of the ICP down. But then they come back and say, oh, we don't have any hardcore proof that it did do that. But atropine in kids, atropine in adults that have a low heart rate. So as you get a little vagal response, you put that laryngoscope in their mouth. So make sure you pre-treat them with lidocaine or whatever. Paralyze them. We'll get to that. And placement, you want to verify it. And this is somebody else's words there. And if you don't plan, don't have your suction ready, it's over there and it's not hooked up. I mean, you're in there, and each time you take a look or introduce a laryngoscope in somebody's mouth, there's a chart or a curve that for each attempt your success rate drops. So it's bad. The more times you go in there and try to put a tube in there, you will have a greater chance of failing or not getting that airway. So you start getting blood in there, because some people, you're starting to tear stuff on them, and you go from a clean, nice, pretty airway to blood and stuff like that. So if you don't have suction in there, and you got to pull out and do that and bag, so have everything right there with you. Make sure you have your BVM. Have it hooked up. Most ambulances have a couple of O2 ports, so make sure you have one hooked up to that. Laryngoscope blades of various sizes, and when you learn a little bit more about intubation, if you haven't already or get experience, most everybody takes a Mac 3 or a Mac 4 unless it's a kid. So most everybody go with a Mac 4. I don't use the straight blades a lot, just never have. I do it with a Mac, but maybe cheating a little bit too, but it works. Here's your semi-rigid style left there. I think that's what they're calling. Rescue airway device, King Airway or LMA. And I got this. That's a King tube. Y'all can pass that around if you want. We call it a backup airway or a blind insertion device, a BID. And basically all you do is go in one side of the mouth. Put this down. Just go in one side of the mouth, inflate that, put 60 milliliters of air in there, and you start bagging them. And you pull back till you get breath sounds or CO2. But usually the teeth will line up over there. So that's a big one. I think that's like 100. It's the biggest one we got. I forgot how many kilos it goes up to. So a 5 is, it's greater than 6 feet or tall. So there's different kinds. So pass that around a little bit. So have one of those. We keep those in there. They say once you take somebody's respiratory drive away from them, you're going to have to do something for them. This is called an air cue. It's an LMA if y'all heard those. We use a lot of those in surgery sometimes. The company that sells these things say it's an intubating LMA, but really not had good luck with it. If you see a lot of the LMAs have the little fenestrations over the opening where the air comes out. This one does it. So this, I haven't opened this one yet because these things are fairly expensive and that one's expired. But they say if you put this thing in and then if you get good ventilations, you can run this Fuji down there, and I forgot the percentage rate, but they say, oh, 95% of the time it's going to come out of that hole and it's going to go right into the trachea. Not the case. So then you don't know if you're in the trachea or not, and you pull that out and you're not in the trachea, then you have to stick it back in, so it's a mess. So once we usually put these in, they're in, and we leave them until we get to the hospital. And that's the same way, kind of stick it in there, maneuver a little bit. You can add air to it if you want to, but usually you don't have to. You just kind of manipulate it a little bit until you start getting breath sounds and CO2. Surgical airway equipment, we keep that. We can do a needle cric if we have to, or we got the surgical cric stuff. Again, not what we want to have to do. Any questions so far? Always make sure the patient's on the cardiac, blood pressure, pulse ox, because you want to watch that stuff, man. If they're not on the monitor and you're in there digging around looking and they're getting, bradycardia because you're giving them a vagal response, or the blood pressure drops, or they're starting to get hypoxia because they haven't breathed in a couple minutes, you need to, make sure that you have somebody watching the monitor. So this RSI needs to have at least a couple people there that know what they're doing. I mean, not knocking, say volunteer or something like that. They'll be watching you. They're not going to be, and you're not going to be listening to that monitor go beep, beep, and then it starts getting slower and slower. Bad sign also. So make sure you have all that stuff hooked up to them. You need a baseline vitals before you start. During, not that big of a deal, but you really need to watch the heart rate and the pulse ox at a minimum. Blood pressure's great. That way you know what you started with. If you give them some Versed or something toward the end, that's going to drop their blood pressure. Like, damn, is that because of the Versed or because of hypovolemic? So we always need a baseline before we start. And for charting purposes, always include initial. Like, that's the first thing you want to do. We hop in there, we'll put them on our monitor because we got CO2 and most everybody does now, but we're going to leave them on our monitor, so we'll go ahead and hook them up. Hit the blood pressure button. And most monitors, if you use Zols, you got to turn that end-tidal CO2 on and let it warm up a little bit. So we'll go ahead and do that and throw it down to the auto zero itself. Because once you hook it up, it takes about a minute to warm up, and that's not the time that you want to be waiting to see if your tube's in place while that thing's warming up. Check IV sites for patency. Again, EMS, you guys have been fighting these people. You want to make sure these IV lines flush well and make sure they aspirate blood, because that's the last thing you want to do is get ready to push something and your IV's no good. So then it goes in the arm or wherever, you're getting ready to intubate, IV's not good, so then you got to stop what you're doing, start another IV, draw up your meds again, so you just wasted a few minutes there. So always check your IVs, and more than one is great. I mean, one will work, but more than one is great. Go ahead, and we got two crews on the helicopter, so it's a little easier. Kind of the medic will be up there at the head, getting all their stuff ready, intubation stuff. The nurse will be drawing up the meds, getting that ready. We don't really verify the dose with our partner. You really can't over-paralyze someone. Accommodate's really not going to hurt them on too many things. But it's always good. I keep a little note card. We got everything listed in there. If you weigh so many kilograms, you get this much. I mean, most of the time you can do it in your head, but kids and stuff like that are a little more trickier. End-tidal CO2, we talked about that. The pre-oxygenate, they say 5 minutes of 100% is best, and it is. So, like I say, the first thing I do, if I get a report on the radio and I know we're going to intubate this patient, if they're on a non-breather, just crank that oxygen wide open. To knock out that nitrogen in their lungs, the reservoir. So that gives you a couple minutes of O2 in their blood. So they say 3 to 5 minutes. So that's a lot of time to be intubating somebody. And usually after about 30 seconds to a minute of laryngoscope in their mouth, you're going to pull out and bag them for a little while anyway. And we'll get to this in a second. We'll skip over it. But you don't want to bag these people a lot unless you have to, because when you bag somebody, where does the air go? Yeah, some goes to the stomach, some goes in the lungs. So you fill those that stomach up with air, then what happens? They puke. If you don't have suction ready, where does it go? Right down the lungs. So we try not to bag anybody. Like I say, if they're holding their sats, that's fine. If they're not and they need assistance, don't be afraid to assist them. But you want to avoid it if you can. If you do have to bag them, you can use crike pressure, and that does help. But it honestly takes a hand to know what it's doing. I mean, if I'm on your truck and you're helping me do something, and then somebody else is doing something else, you kind of have to have like a third or fourth person there that knows what they're doing to hold crike pressure down. So that's good to do, and if you got one there, then you can't be doing something with your other hand. So if you got the people do that while you're bagging them, it's not a big deal, but it helps prevent vomiting. And we've already talked about this stuff. These are your pre-treatments. Lidocaine for head injuries to reduce the ICP during intubation. And that's controversial. The state protocols say it, and if you want to get up there and slam 100 milligrams in, 75 milligrams in, we can say that we gave it, we say we considered it. It's probably not going to hurt them either way, but is it going to help them? You know, who knows? Well, like I say, we used to do it almost every intubation, but we don't anymore. We don't even carry it in our little leg pouch anymore. Atropine 0.02 per kilogram, and to a max of 1 milligram. So that is a lot of atropine. So it doesn't take a whole lot. You make sure you give it to kids less than 12 because they're going to tend to bagel down a little bit more and become bradycardic. And it says give to patients requiring a second dose of such. We hope we don't have to give them a second dose of such. If you're doing that and you've been in there a little while, then they probably are bageling down. All patients should be adequately sedated when possible, and we'll get to the drugs in just a second. I think the state's got fentanyl and Versed coming up. Is that right? For the new protocols. Versed's better, but if they're a trauma patient, they're hypovolemic, some sort of head injury, and they got a low blood pressure, you want to stay away from Versed because it's going to drop them like crazy. Now, if they're a stroke, they got a high blood pressure, then Versed is going to be good for them because it's going to get them down. But be careful with strokes. You don't want to take too much blood pressure away with the bleed. All this RSI, I mean, you're going to have a huge chart when you RSI somebody, and you should. So, yes?
Will you tell them the importance? If you back up that one slide, it said that all patients that are going to be paralyzed need to be sedated. We tell them the importance of sedation.
Yeah, I'm going to get to that. It's kind of a little earlier than it should be. It will come in the drugs. So our Tomidate, you may see it Amidate, A-M-I-D-A-T, Tomidate. I don't know why they call it that. So it's almost like a date rape drug. It's very short acting. Not that I've ever considered it. But it's very, ketamine. Ketamine's the good one, and then we'll get to that in a second. It's very short acting. We're using ER a good bit just to reset a shoulder or reset a hip. Man, you give them that Atomidate, and they're sitting there talking to you, and they'll just start snoring. And they're breathing, they're snoring. You can't wake them up for nothing. Pull that hip back in, pull that shoulder back in. About 5 minutes, they'll wake up. Have y'all started yet? But if you do a Tomidate, we do keep a BVM at the bedside. We usually throw them on some high flow, well not high flow, but 4 to 6 liters per minute with a nasal cannula just to wash them, especially old people have sleep apnea and stuff like that. Like I say, about 3 minutes is all it's good for. It's very short acting. Again, document, remind me toward the end of the class. We'll talk a little bit about documenting. It's not a narcotic, it's a non-barbiturate. It's a hypnotic. I've never tried it. Maybe I need to try a small dose of it. Blah, blah, blah. Sleep is produced within 1 minute and lasts less than 10. Usually you get about 3 to 5 minutes out of it. This is your ketamine. Tomidate was on back order. All the drugs were on back order about a year or so ago. We had to switch to ketamine. We really didn't have good results with it. Ketamine's a good drug in kids and ORs and stuff like that, where you can keep people NPO, things like that. But the dose, let me go back to the dose. So 0.3 milligrams per kilogram. So almost everybody would get a 20 milligram, no matter what. Somebody, it's a little bit bigger, they may go ahead and give them 30. It comes in, either come in 20 milligrams or 40 milligrams. So most of the time we'll just throw up a whole bottle and we'll give 20 milligrams of it, and that'll usually do the trick. Now somebody bigger, 250 pounds, we'll go ahead and give them a 30 milligram dose, which that's what they should get anyway. But most of the time 20 milligrams will do the trick. The ketamine, get back to it, we just didn't have good results with that. I'm pretty sure it's in the protocols too. It just didn't, we didn't have good results with it. It doesn't do what etomidate does. So this is your good date rape drug right here. Vitamin K, people sell it on the street. I mean, and
Horse tranquilizer, isn't it?
it may be, they probably do use it in horses.
Pretty sure it is.
So we used to sedate kids with it a lot when I worked in Atlanta. And it wouldn't really put them to sleep like etomidate does. It would knock them out. They would be there with their eyes open. They may look around a little bit or have some nystagmus or something like that. But I mean, it totally dissociates everything. When those kids would come out of that drunk or that stupor, they would be cussing. They would be doing all kinds of stuff, and the parents was like, "Wow, where's my kid?" So, does work, not as good as etomidate. It's going to make them slobber and drool and everything else, and that's not what we need when we're doing an airway. So when we did this in kids, we would give them some Robenal, which kind of is almost like atropine. It dried them up. So we'd give them Robenal about 30 minutes ahead, then give them some ketamine. This ketamine is going to make them have secretions and stuff like that, and Robenal will dry them up. You're going to get a noted increase in blood pressure when you give them the ketamine. If they need an airway and they got a stroke and their blood pressure's already 200 or 300, then I guess you got to do what you got to do. But just know that if you got a decent pressure, give them ketamine, it's going to bump it up. Here's your sucks. Good stuff. I've never, take that back. We had a flight this weekend that they had to redose the guy with sucks. Just cause he didn't take it to him for some reason. So I won't get into the mechanism with it, but it usually starts in about 30 to 60 seconds, and it lasts about 2 to 3 minutes. So that's right there with your etomidate. So it takes a little longer. That etomidate is real fast acting. So what we usually do, we'll push the subs first, and then the etomidate. And again, you don't want somebody paralyzed that knows what's going on, so they need to get that etomidate pretty soon. It just seems to take that subs a little bit longer to start working. It really doesn't matter which order you push them in, so sometimes they're right there around the same. Yeah, you may get up to, it says 2 to 3 minutes, gradually up to 10. I've never seen it last for that long. Some people do. If they have like a decreased mental status anyway, you may not see them starting to wake up a little bit from it. You'll learn your lesson when you paralyze somebody with sucks and you intubate them and you're all happy, whatever. All right, let's get them to the helicopter. You get them to the helicopter, and by the time you move them back and forth, they're starting to wake up. So you're going to be reaching for something else. We'll get to that next drug in a second. So it doesn't last long. It's usually 1 to 1.5 milligrams per kilogram on adults. So 70 to 100, something like that, will work. But take that back. So double. It's about 150. If you have people that have been on drugs and meth and stuff like that, they tend to eat through these paralytics for some reason. Their metabolism is so high, they'll eat through these paralytics. So you may see the sucks may not work. You may have to give them a little more. You may have to double the dose to 1.5 milligrams to 2 milligrams on these people that we suspect are on drugs. Because not only does it work well for them, it doesn't last as long. So we start giving the rock or the Zimuron, who we'll talk about in a second. You may see it, instead of lasting 30 minutes, it may last 15 minutes. You're like, man, why are they waking up? Why are they waking up? Or people are on narcotics and different drugs that have a history of it. They just tend to eat through this stuff. Kids' metabolisms are high too, so increase your dose to at least 0.5 or another whole milligram for them because they'll eat through it. Can over-paralyze someone, so don't worry about that. Suck should be refrigerated. We have a little refrigerator of it. It's good for about 30 days from the time you pull it out. So what we'll do, we'll take a Sharpie and we'll write on it and keep it out for 30 days. And yeah, maybe someone's been left out 40 or 50 days. It still works, but you don't want to get in a situation where like, uh-oh, my sucks didn't last because I didn't work because I left it out of the fridge too many days. Sucks is cheap. Throw it away, get you some more. We carry a little leg bag, so that's what we put our sucks in. It usually comes in like 200 milligram vials, so one vial is usually enough to do a patient pretty good. This is contraindications to sucks. When you give them, it sucks. It causes the release of all that potassium in the blood or in the cells to come out to the blood. So if they've already got a hyperkalemia, you don't want to do that. If they've had some sort of lobe injury, nothing to do with hyperkalemia, but you don't want to give them the potassium for that. I think it causes an increased intraocular pressure. So it is contraindication. You may want to ask your doctor. I don't know if somebody's got something in their eye. I mean, they may need an airway as well. So there is a backup for this. Crush, burns, rhabdo, extremity fractures, greater than 24 hours. I mean, unless somebody's been laying in a car all night or under a car or under a tractor for a couple of days, or not a couple of days, but a day or something like that, you really want to take that into account because these people have a lot of, once you pull that stuff off of them, they'll have rhabdo, they'll probably have some potassium in it, and it'll definitely cause a hyperkalemia. So burns are the same way. Spinal cord injuries over 48 hours old. Never really seen that, but again, your people and the people we fly are not going to have these. It's usually when it happens, we usually know about it. And sucks is contraindication. I've never seen a sucks contraindication in the field on our end of it anyway. Malignant hypothermia, most of the time you're not going to know that. This is something that they'll know if they've had a surgery and they've been intubated before and they have a malignant hypothermia. So, I mean, if the family gets up there and tells you, hey, they got malignant hypothermia, you're not going to paralyze them, are you? But, oh man, they need to do something else. Muscular dystrophy, things like that. It says use caution in them, but most of the time, how are you going to know? Rocuronium is your next dose there. So you get 0.6 to 1.2. I suck at math. Went to public schools. I always do 1 milligram of rock or Zimiron. But keep in mind, we'll get to Zimiron in just a second, or we'll call it Zimiron rocks, all the same thing. It lasts 30 minutes. So instead of this 5-minute sucks you got and you take somebody's airway away, you're going to be bagging them for 30 minutes or until you get a tube. So I've never done that, knock on wood, never seen a contraindication to it. But rock lasts a lot longer. I got rock on here. Right. Rock would be, after we intubate somebody, it depends on where we're going, whether we give them this rock or the vecuronium. You may hear it called Norcuron, you may hear that called Zimiron, they're the same thing. If we're going to Columbus or somewhere, we may just give them a rock. The good thing about rock or Zimiron is it's already in a liquid form. It's easy to draw it up, give it to them. Really not any contraindications to it. Blah, blah, blah. Usually takes, I've seen it, it doesn't usually take 3 minutes to totally paralyze them. When we give it, most of the time they're already paralyzed. So we go ahead and give it, and we get 30 minutes out of it. So the VAC, on the other hand, it's in a powder form, so you have to reconstitute it, take a flush, slam it in there. It comes in 10 milligram vials. It's a powder. You put 10 milliliters of saline in it. You got 10 milligrams, and they get 0.01 per milligram, so a 100 kilogram patient just take the whole vial. So usually round that up to you really can't over paralyze somebody. And it usually 2 to 3 minutes it takes to work, and it does last 45 minutes to an hour. Now somebody that had a drug problem or on meth or something like that, maybe VAC would be a good choice for them because it's going to take them a little longer to eat through it. It tends to be a little bit stronger. So VAC's good. If we got a long transport time, we will do VAC, but most of the time people just reach for the rock and do it. The laser doesn't work too good. This is the main thing right here. Before you go up and start slamming anybody with these long-acting paralytics, you want to make sure that ET tube is in there. You want to verify it by auscultation, end-tidal CO2, chest X-ray if you can. Get somebody else to listen. So that's the last thing you want to do is paralyze somebody with these long-acting paralytics and they not have an airway. That's bad stuff right there. Anybody know why we avoid long-acting paralytics with seizure activity?
You wouldn't be able to tell they're having a seizure.
That's right. So you wouldn't. Somebody smoking in here?
That's not
Let's keep looking around. Am I that boring or? So, Anyway, yeah, you're right. You don't know if these people are having a seizure. So how are you going to treat it if you give them Ativan or whatever? So they may not be twitching and stuff like that. So just FYI.
Well, it doesn't matter if they're having seizures.
It really it doesn't. But if they're having frequent seizures, they have to come out of it. We want to treat them with something, some sort of I can't think of the name of it now. But, you don't have to give them the Ativan or whatever for it because they're having a seizure to stop it, but you want to kind of stop the seizure, the electrical activity in the brain. That's what you want to stop. So, when we get ready to intubate somebody, do our meds, get everything pushed in there. Once you push that stuff, you go ahead and get your partner to do some crike pressure. That usually helps out. Everybody done that before? Or done it? There's a mnemonic called BURP, B-U-R-P. It's pull it down, back, up, right, pressure. So usually push that down. You may have to tell your partner, let off a little bit or give me a little bit more. And if they know what they're doing, they can manipulate that around a little bit into your view. So if you think about it, you go to the patient's right, and that's the side that you come in from. So hopefully they'll push those vocal cords into your view by going to the patient's right. This is what you want to see. That's what you don't want to see. And a lot of times that's a laryngeospasm right there closed. And a lot of times those sucks will make it relax. Now, sucks is a skeletal muscle. Somebody smoking out there, Nick?
They're smoking, they're smoking out there by the air conditioning unit.
Maybe the janitor's up there.
Yeah,
So, if you are able to get a view of the vocal cords and they got that, give them just a second. Then hopefully those things will open up. A lot of times, and it works the other way too. If you hit them with that bougie, they may open up. Sometimes if you hit them with that bougie, they'll close up like that. And always, if you see those things go through the vocal cords, that's great. And a lot of times you may not see it. And we'll show you how to verify that. But if you can see it, that's great. You want a good view of it to make sure where it's going. So once you do that, inflate the cuff if you have a cuffed ET tube. And all these things are great things to chart. You want to cover your butt like crazy on an RSI chart. You don't want these people to, you don't want to dislodge your tube en route. You don't want these people to have a noxious brain injury because, oh, they said, oh, you didn't intubate me right, or you didn't intubate my family right. Never mind, they weren't breathing the 5 or 10 minutes before you got there because they were clinched down. So direct visualization, you want to chart that. Say I saw the tube go through the vocal cords. We didn't have any gurgling over the epigastrium. Had bilateral breath sounds. We had a positive end-tidal CO2 on our monitor. Fogging in the tube is not as reliable, but it is reliable. I wouldn't use it for a definitive tube placement. Chest rise and fall is great, especially pulse ox. If pulse ox starts to go up. End-tidal CO2 breath sounds are the most important. A lot of times the weird traumas and like diaphragmatic hernias and injuries and stuff like that, you may not get breath sounds. You may not get breath sounds because they have a pneumothorax, or you may get gurgling in the chest. So that's few and far between them. Again, secure that tube good. Make sure it's tight. I mean, look care if it's scrunched down in the patient's face and pulling them out. We don't want any play because if you think about it, you may not have an inch or two. So you move that around a little bit. You get somebody not paying attention while you move them. The tube's out. It doesn't take that much. And again, got these patients paralyzed for 30 minutes now. Crap. I mean, yeah, we may get that airway again, but then we may not. And if you got anybody work for our service? I need to work for a service. Anybody got work for service? Y'all got an end-tidal CO2 already? Isn't it like standard now? Make sure your monitor print the waveform on the strip. Yes. Yeah. Always attach that, make a copy of that and stick it on the chart, scan it in, whatever you got to do. Because that's the last thing you want to do in 5 years. You don't remember this call coming back to, oh, you killed so-and-so because you didn't get the tube in there. Well, there's a waveform. How did it? Hospital did it. ER did it. So after we intubate them, remember, time of date, 3 to 5 minutes. Sucks, 3 to 5 minutes. And they're fighting us before, and we only knocked them out for 3 to 5 minutes. So what are they going to do? Now they're waking up and they got something in their throat and they can't holler. So the first thing they're going to do is going to grab that. So as soon as we got that tube verified, this is what we're going to do. Give them a long-acting paralytic. But first, you ever heard the stories in the OR, I was put to sleep, but I could feel everything. That's what these paralytics do. They don't do anything to your mind. They do everything to your body. So to paralyze you right now, you can remember everything I was saying, but it would suck. Because you couldn't move, you couldn't do anything but just lay there. So that's what happens. The paralytics have no effect over what the brain does. So they work, you know, at the muscle level only. So we give them some Versed, midazolam, too, so they can't remember it. It's like a hypnotic. And it's 0.05 to 0.1 milligram, 3 to 5. But that's a little dose. Usually you can take somebody, if their blood pressure's good and they're, you know, they're not a little low grandma or whatever, they can handle 5 milligrams of Versed, no problem. But you may want to start around, you know, kids. You could always use something else. You're starting to get around half milligram, 1, 2, 3, stuff like that. You don't want to give somebody too much Versed because it's going to kill their pressure. So keep that into account before you give them a big slam of Versed, especially if you push it fast. It should be given over a couple minutes anyway. But like it says, they're usually 2 to 4 milligrams IV. Give it over 30 seconds to a minute. You got a question?
On average, when you do RSI, how many drugs do you put?
We got sucks, we got etomidate, we got your post-intubation stuff, so either Versed or fentanyl, and then a longer acting paralytic. So about 5 or 6. But you know, you give your 2 initially, etomidate, sucks, intubate, then you go to your post management. Where are we at? It's a good benzo. You can use Valium, I think, but I wouldn't want to. We used to use Ativan a lot, and we still do. We give them high doses of fentanyl. Now think about it. The only reason you don't give people a lot of morphine and stuff like that when they're awake is because you decrease their respiratory drive, and they do stop breathing on you, or the blood pressure drops. I mean, you can sedate people with technically whatever you wanted to if you had it, but these are the ones of choice: Ativan, Versed, fentanyl. Yeah, they will never remember that they got Versed. Probably never remember they got intubated, even if they were wide awake. Get your hypotension with Versed, so use caution with that. Your long-acting paralytics, back 30 to 45 minutes, maybe an hour, maybe 40 to 60 minutes, but usually it's longer than 30. The rock is right about 30 minutes. So again, depends on your transport time, what you want to give. You can redose them a rock a time or two. It's just easier because it's already pre-mixed. Make sure you keep that end-tidal CO2 on every move, and especially during the chart. When you're doing your chart, you want to document move patient to wherever. Yeah. Confirm tube place with end-tidal CO2, bilateral breath sounds, whatever, chest rise and fall. You want to cover your butt every time you move that patient and chart that we have good end-tidal CO2. We won't get into what their end-tidal CO2 should be, but usually not less than 35 to 45. You guys will learn that later on if you don't know it already. You can, faster you bag them, the lower it's going to go. Usually when you intubate these people, the good thing about it, they haven't been breathing good for a couple minutes, and as soon as you put your end-tidal CO2 on, their CO2 is 50, unless you're at a hospital or something like that and they've been bagging them for 50, 60 times a minute, and then their CO2's 15. I don't know, does anybody carry a band in here on the ambulance? Probably not. That's the gold standard, is to put them on the vent, but hey, if you got, all you got to do is bag them, and bagging them is fine. We used to bag people to the hospital. Even if it was here at Columbus, it's like, all right, we'll just bag them. But it takes a couple minutes to set up our vent. We got to hook the vent circuit up to it. It's got 3 little pressure lines that's got to go on it. Now the gold standard, that way they're getting, an adequate tidal volume. They're getting PEEP. They're getting, the right volume every time, the right rate. So now we've gotten to where they want us to put the vent on every intubated patient, no matter how short the flight is. The documentation, like we've already talked about, why we done it, why we chose RSI. Because even if we don't get this airway, and we had a good reason for it, at least we can say, you know, this is why I done it, and it fits the protocols. So, you know, if I screwed up, or not that I screwed up, but if we couldn't get it, some people just can't intubate. You hear these stories at the OR that, you know, you get anesthesiologists and CRNAs that intubate people every day that can't get these people intubated. So, I mean, just some people you can't intubate. So, but make sure that you cover your butt on why we chose to RSI. Get as much history and stuff you can. Remember, use your lemon rule. Look them over good. Get your vital signs before and after. We usually set our monitor, put it on cruise control, either 5-minute or 10-minute blood pressures, depending on where we're going. So that way you can watch it and make sure you keep an eye on that CO2. And I don't know which kind of CO2 you got. Usually the CO2 cords are shorter. Ours is called the, I forgot the name of it. It's a little orange tip, but it's like a plastic tube that hooks right to our monitor. Some of those olds have like the little seat that goes clamps over the sensor, but those are usually shorter. So if you're moving that monitor way over there, you've got it down on the feet, be careful don't pull that entire CO2 cord because you'll clamp that tube out. Chart your medications good. And one thing they used to tear us up on, and they still do, and they'll tear you up on, is not giving an appropriate sedative after you intubate these people, or forgetting to give a sedative. That's just bad. These are the people that the stories you hear about is going to tell you everything that you said while they were in the ambulance with you because you didn't sedate them. So just think about it. Would you want to be laying there with a tube in your mouth and not being able to move anything, and remember all of it? So make sure you give appropriate sedation and appropriate doses for it. Chart your size and depth of your ET2. The bigger the better. Used to, everybody says what, 7.5 is the common size. I mean, first thing we pull out is usually an 8. Because depending on what's wrong with them, we get, you know, people that swallow teeth or swallow whatever, and they need a bronch or something like that later on. Well, these doctors don't like a little 7 ET2. Now, if that's all you can get, that's great. But the bigger the better. That way they can, you know, remove stuff, or they can bronch them if they need to with these size 8 ET tubes. I think 8.5 is about the biggest I've ever done. And also make sure you chart your depth. What's the general rule of the depth charting on the ET tubes? Anybody know? Should be 3 times the size of the ET tube where your centimeter should be. So if it's a size 8, the line should be around 24 at the teeth. If it's a size 7, it should be around 21 at the teeth. That way you always know. That's one of the first things we do is we'll look at that. We're like, okay, if it's a 21, we move them a couple times. We look again. It's at 17 now. Uh-oh, might have been screwed up. Or we look back, we know it's at 21. That's just another way of saying we know that tube's in there. Or at least it hasn't moved up. It may have come out and then went back in. But make sure you know what it's secured at. That's just one more thing. And document that. Because, you know, if it's too deep, you'll do a right main stem. I'll say this while I forget about it. If you do use that bougie and you don't see that ET2 pass through the cords, but we got breath sounds or unilateral breath sounds, but we got CO2, so we're in the trachea, and we look at that and say we're on a size 8 ET tube, and instead of 24, maybe like 27. So pull up, bag, and pull up and bag. Get somebody to listen for you until you get bilateral breath sounds. A little bit at a time, because we know where that tube should be about right around 24. So if you ever go in and see somebody where the BBM connection is sticking that far out of the mouth, that tube is way too deep. Something's wrong there. So we'll back that out a little bit till we hear breath sounds, a little bit at a time. If we don't ever get the tooth, what time is it? We good?
It's about 12.
Oh, we got plenty of time. Only 2 more hours. Anybody got any questions so far? So if we don't get this tube, we need to remove the tube course and start using the BVM. Remember, they don't have an airway drive anymore. They're not breathing on their own. So bag them. Kind of fall back to your BLS airway stuff. You can do an OPA if you have to. You keep that crack pressure down. If you got a free hand to do it, that prevents some of the gastric distension. Use your burp maneuver, back upright pressure. I don't know what they're talking about really. Remedicate them as needed, because you don't I guess if you don't get it and that you want another shot at it, then you might want to give them another dose of accommodating subs to try again. Let your partner try. And, you know, granted, I don't know how you're going to get experience if you never have experience with it, but usually somebody intubating, you want the most experienced intubator there. So I walked into a hospital one time, I'm not going to say it because it's close to around here, and we walk in and the doctor says, "Who is the best intubator?" It's like, oh man. So we walk in this room, there's bloody ET2s, there's bloody blades, there's a video laryngoscope, Godscope. It's all laying on the floor and it's like crap. Those are bad. Those are the ones that you try so many times and then your success rate just starts to go to the floor. And we never did get that guy. My partner was one of the best intubators that I've ever flown with. But I was like, oh man, when calls are bad, they're bad. I mean, it's just Murphy's Law. If it can happen, it will, and it stinks for everybody involved. You know, if you can't get it 2 or 3 attempts, then you probably should stop trying, because, you know, think about it, you're in there 30 seconds, you're moving stuff around, you bag them a little bit, you go back in there, you're in there 30 seconds, 45 seconds, another time, you're going to have to redose them anyway, so you're starting to get close to your 35 minutes.
Just because you couldn't see, or just because it's...
Just because you can't see, and it may be blood, and it may be just big, or they just may be anterior, you just can't see anything. And it stinks. It's a bad feeling. We did a stroke up at Dayville the other day, and she looked like she was going to be easy intubation, but I mean, she wasn't. It took me 2 attempts to do it. And anytime you put that laryngoscope in the mouth, that counts as an attempt. If we weren't recording, I'd say chart it any way you want to, but technically, anytime the laryngoscope goes into the mouth, that counts as an attempt. That's why you need to have everything right there ready. Have somebody handing you stuff. I mean, once you see those vocal cords, never take your eye off of them. You just grab. That's all you do is grab. Never take your eye off of them. Because I mean, you got it at a good spot, and once you drop it down, you may never see it again. So make sure you have your backups in place. The King and the LMA, the intubating LMA air cue, same thing. King 2, you pass it around, and they work. They're not as good as an ET2, but they will work. You can ventilate through them. And it's funny, I mean, you get to the hospital sometimes, and the first thing those doctors do, oh, I can intubate this person. And they wind up taking that LMA or that King tube and putting it right back in after they try a couple of times. So, surgical crics, needle crics. If we can't, you know, there's cannot intubate, cannot ventilate times. And those are bad. Those are the days you want to wear that extra deodorant because you'll be sweating. So consider those surgical crics and those needle crics. Blah, blah, blah. So I don't know what happened to that guy. There's a little bitty, I don't know if that's some sort of stenosis or something right there. So I don't know how good you can see it from out here. But I'm not sure what happened to this guy, but he's got himself a trach, it looks like. That's a bad day. So, College of Anesthesiologists is causing failed intubation after 3 unsuccessful attempts in more than 10 minutes. That's a long time. It's going to seem like, it may seem like 5 minutes to you, but you look at your watch, like, dang, we've been here a long time. We need to hurry up and do something. It's good to have a partner. You know, you're focused on getting that airway. You need to have your partner just go ahead and elbow and say, hey man, we need to go into the hospital, and let them sort it out. Again, this is I stole some of these slides, and they're kind of based on air medical stuff. So if we couldn't get an airway, and even your state protocols say if you can't get an airway, go to the closest ER no matter what, no matter if it's not a trauma center or what, go to the closest hospital. Doesn't mean there's going to be someone that's more skilled in intubation there than you are, but just do that. That covers your butt. Like I say, some people you just can't intubate. Then we have to do this. As soon as we have a failed airway, we have to call our medical director. She's gotten better about it, but she used to ream her butts when it first started, because actually it's her license too. It's going to be your medical director's license. You can't intubate these people. They want to know why, what happened. Get your educator involved if we need to do some remediation training or what you face, things like that. Be good to know. Everybody knows the dope mnemonic. This slides tube, so make sure you verify your position. If it's got some mucus plug or something in it, if it's kinked or bent over, if they have a pneumothorax, or if you got equipment failure, you got a hole in your BBM, your vent tubing's come off, things like that. So always make sure you watch that monitor for bradycardia, hypoxia, because it will happen. You know, if the patient's blood pressure goes up or sat goes down or something like that, you really want to watch that monitor. Sometimes maybe they're analgesic or the Versed or fentanyl, something to wear off. They'll be trucking along, and all of a sudden that blood pressure will be 200. The heart rate will be 150 where it was 120. And you got to start considering pain or something like that, discomfort. Give them another dose of Versed or Ativan or fentanyl, and you may see that start to trend down a little bit. So, you know, most of the time we see treat your patient, not the monitor. And this time you kind of have to treat your monitor a little bit too, because that's the only way that you know what's going on with your patient. We got any questions? Well, thank y'all for having me. Y'all relieve me.